Okay, ladies and gentlemen, please have your seated. Now let's move on to the last session of today. That is the industry session, focusing on the cutting-edge CT technologies. So first, I'd like to invite Deborah to give a talk on behalf of GE Healthcare regarding the cutting-edge cardiac CT technology. Let's welcome.
Okay. Thank you so much. My name is Deborah Umloft, and I'm the Cardiology Care Area Leader for GE Healthcare. My responsibility is both for cardiac CT wing-to-wing workflows and also nuclear cardiology. It's an esteemed pleasure to be able to be here amongst you, and I want to thank the SCCT organization for allowing us to be a platinum sponsor. So I do not have to tell you, you know that how challenging healthcare has become globally. Besides being a geopolitical or reimbursement challenges, which are beyond my control or anything like and probably even beyond your control as well. The patient population, the population is getting older and sicker, and then just the challenges around staffing. Your world has become a lot more challenging than ever before, and it doesn't seem to be stopping either. And so with this challenge at hand, healthcare is moving faster than ever, and the demand for innovation is constantly on us as an industry to be able to help you be able to take care of your patients. And so you see innovation everywhere. People have great ideas. We have researchers right in this room who are cutting edge things, but finding that right impact that can truly impact patient care is really what we're doing. And so we ask ourselves, why are we doing what we're doing? And it really starts and ends with the patient in mind. And with the innovation, with the patients, why are we doing what we're doing? And by investing in over $3 billion, we're really empowering the next chapter of healthcare with these innovations and really putting the patient centric into what we're doing. And how are we doing this? Well, what we're doing is we're looking at the disease states. So, I am one of the care area leaders in cardiology care area. And looking at that, we have a lot of really good smart devices, but can we make it smarter and faster and better? We work very closely with the drug manufacturing, device manufacturing, to make sure that what we're building actually impacts then the downstream care that you're able to do with your patients. And then we have that digital thread too. So it's great that we have really smart devices, but unless it actually connects to the electronic medical record, makes everything go into the report, then without having everything together, it really becomes a challenge. So what we want to do, and we take again with that patient, that start to end journey, put everything together, and this is the investments that we're choosing to do. So today I'm going to share with you the exciting developments of our ever-growing portfolio of products in cardiac CT. And then towards the end of the presentation, I'm going to be talking about our new announcement with Photonova Spectra, which is our new photon scanner. But you can see from this image here that our portfolio is pretty vast. We have everything from the Revolution Maxima, which is, the placement of the scanner is really in the communities, and the value of doing that is so that we can actually bring our scanning and access to cardiac care to the communities. And then everything from the Ascend platform, which is really a workhorse, the Apex and now Vibe scanners, and then again the Photonova Spectra. And then introduced this past year is the Revolution Vibe. But again, going back to our patients, we really need to make sure that we simplify the experience from our caregivers, because even if you have the most advanced detectors, if the technologists are not able to easily scan, everybody really needs to be a super user, and so you can never really effectively take care of your patients. So already with our standardized imaging protocols at GE Healthcare, everyone can really be an expert, and doctors can enjoy being doctors instead of being technologist supervisors. In 2025, our biggest announcement was the Revolution Vibe, a scanner that's optimized for cardiovascular imaging, but capable of really anything that you want to do in your cardiovascular center of excellence. So like its big brother Apex, it offers consistent image quality for every patient, effortless AI augmented workflows with the whole heart CT centimeter coverage. And also, if you have patients who are not able to have a stable heart rate, maybe they're a trauma victim, we also offer the ECG-less technology. And again, going back to that effortless workflow, you don't have to be an expert. It actually builds right into your workflow as a simulated ECG. So again, for every patient, we're able to take care of them. In November, just a few months ago, we announced the latest capabilities for Apex. So first, I'm just going to kind of step through those because these are products that hopefully a lot of you are already familiar with. And so the Revolution Apex and Vibe now includes an all-new CT1 interface, and this is simplifying the already simple workflows, and then adds additional benefits for especially trauma cases. The reduction up to 75% of most clicks. So again, even though we already have a simplified workflow, we can always do so much more, and especially with AI automation. We streamline operations such as the post-processing steps, like best phase selection, snapshot freeze motion correction, and now we also have cardiac auto views that will automatically send calcium scores and vessels pre-labeled to your PACS reviewing. Putting it all together, the easy interface combines with the automated technologies in the background, and then following it up with post-processing with what we call AW1, which is an ecosystem of AI-enhanced post-processing software that streamlines the entire workflow. So just kind of stepping it through, the technologist is in the front end, they have that simple user interface, but in the background, this AI-augmented technologies are really doing the work in the background for you. Again, we're taking the workflow, we are using AI to kind of help automate the processing so that you can have consistent results on the back end. So again, you might have heard of our CardIQ suite. This is the AW1 experience that I'm referring to. All of the coronary artery assessment tools are built into an automated and guided workflow that takes you to the final conclusions that you can add to your report. So while it's AI enhanced, you as a clinician still have full control of your results and then adjust as needed. Okay. And again, with all of these standardized and flexible workflows, you should have the expectation of it having consistently exceptional results. So these are examples, and I know professors showed this slide in the earlier presentation, but it's also for a variety of scenarios. So not only coronary assessment, but you can also count on, Revolution Vibe and Revolution Apex with the whole heart coverage. To have the exceptional image quality every time for structural and functional heart assessments as well. So despite technical advancements, coronary artery evaluations in patients in atrial fibrillation, of course, is challenging and can typically have unsatisfactory results. But prior, results, unless you, somehow get lucky sometimes, or you do a lot of beta blocking for management, it typically was discouraged to have patients who, have atrial fibrillation, especially in the severe cases. So the centers that maybe have stroke centers, they might be AFib centers, find like a higher population of patients with this, this problem. But thanks to ECG-less, which actually simulates the EKG rhythm, we build that right, like I said, we build that right into the workflow. So if you have a stable heart rate and you have a dependable heart rate, great, use the patient's heart rate. If it's not, instead of either canceling the exam because you just can't get through the study, or wasting resources, switch it to the simulated ECG and then just continue the scan, and the results are just spectacular. Some of the other things that are really nice is, for a long time we've been talking about triple rule-out studies. So this is a case where a patient had acute chest pain in the emergency department, had clinical suspicion for also PE. So being able to enable what's called hyperdrive, you're able to get, because you have the whole heart coverage, you're able to, within, the same scan and the same amount of contrast, be able to get both the PE study and also the heart done in that same study. And the same thing if the clinical suspicion is having an aortic dissection, same concept. By using the hyperdrive, be able to get the two studies within one in the same contrast dose. So the next thing I want to talk about is really our exciting new baby, which is the PhotoNova Spectra. This is a photon counting platform that's offered in two different configurations. One is a 40 millimeter and another is an 80 millimeter configuration. And it's built on these three pillars. So we don't believe that you need to sacrifice sensitivity when you're focusing on high resolution imaging. And we believe that you can actually have the best of both worlds. And you should also not have to be a super user in order to use your system. So the third pillar is really a simplified workflow. So across our entire, I talked about our portfolio of products. Every one of those products, we want to have that simplified user experience. So when I talked about that one UI, the new UI interface, it's on the Vibe today, the Apex, and also the PhotoNova Spectra. And the benefit of this is, again, your technologists, they probably will need to rotate between these scanners, and they should not have to be super users between each of these scanners. So with the detector, I just kind of want to briefly talk about that. We're using deep silicone with a wide variety. It's a widely available mineral, so silicon, and it can accurately count and utilize all of the photons, and also measure the energy accurately using an 8-bin technology. So this slide just kind of talks about the advantages of using deep silicone versus the other types of detectors. With our detector coverage, again, we have a 40 millimeter and 80 millimeter. We're able to do the heart coverage within 2 heartbeats. And thanks to the 0.23 second rotation speed, we also have the hyperdrive, which allows us to obtain a complete chest scan within 1 second. And again, this is with the 80 millimeter configuration. But there's also more to this story, and this comes with the main reason. We started talking about photon counting decades ago, actually. And so a long time ago, maybe, 5 years ago or something like this, we decided to change our direction because we knew that we could do so much more with these photons that are coming into the scanner. We didn't know how at the time, but we knew that it was not achieving what we actually wanted to do. And so we wanted to, of course, have high resolution. That's the benefits that we're seeing, from photon counting for a very long time. But, these photons are just so much more. And kind of learning what, from the original photon counters, which is PET-CT, we learned that with the 8-bin technology, we can also allow us to have spectral fingerprinting and do so much more with what we're doing. So now there's new algorithms that allow us to be able to calculate material decompositions like never before. So you can kind of think of it as like spectral imaging on steroids. So full fidelity imaging, this means that we can always, when we're scanning, it's always on. So we're always capturing photons with this, and the result of capturing all of this is the high definition monochromatic imaging. But then we're able to also calculate material maps for water, iodine, calcium, uric acid, fat. So that means that we can do so much more than we've ever been able to do before. And it's not a choice. You don't have to choose between, are you going to get these monochromatic images, and then am I also going to get spectral or these other maps? It means that you're going to get everything because we're always on. We're always turning that on. So the results that we're finding is completely stunning. So while conventional imaging requires 2 acquisitions in order to get the spectral imaging, we can now do the same image and actually with less dose because, again, we're not compromising on the sensitivity. This is just an example of then using thoracic imaging with really the same concept. So again, our third pillar, we're also investing heavily on the post-processing because we can have the best detectors, but if you don't have anything to do, deal with the results afterwards, so we're also investing in the digital world. So examples, we recently announced Snapshot Freeze 3. So now this is the motion correction algorithms. This is now optimized for high definition. So of course, photon counting is included in that. It is now optimized also for spectral, for non-contrast cardiac images, such as your calcium scores, and also multi-phase functional data. So all of these things now have been improved with its Snapshot Freeze 3. Also, and it's not on this page, but another advancement that we've done is cardiac auto view. So I was talking earlier about our effortless workflow with cardiac auto views using AI technology. The software is able to calculate in the background and be able to send the results 0-click to the PACS with the post-processing. And with spectral imaging, our workflows have had a lot of redevelopment as well as far as the post-processing software. We wanted to make sure that it was more intuitive to use, but also very flexible, because there's a lot of things that with this whole, the spectral imaging and the energy material decomposition that we wanted to maintain the flexibility of being able to do so much more with this data. So I'm just going to quickly show you some of the cases that, and the stunning details that we've been having in our earlier evaluations. So we are still going through, just in full transparency, we are still doing product evaluations with our patients. And so as we get patients that are coming through the scanners, we're able to capture the details of what they're doing. This is, of course, showing the clear delineation of vessels with calcium deblooming. And the nice thing, and I'm really encouraged by what we're doing in this photon counting area, because it's really impacting the clinical decisions that our doctors are able to do. So you're able to see more, but then the information, you're actually able to do more for your patients. So this is a patient who has, it's a low dose, ultra high definition cardiac imaging with soft coronary plaques, spotty calcifications. Where the arrows are pointing to, completely missed on EID. So you're just able to see where there's the mixed plaque that, you just completely missed. And this really changes the clinical directions and the direction of how to treat the patient with this information. Again, here's another cardiac imaging with a patient with mixed plaque. Here's an ultra high dose, or low dose, ultra high definition cardiac imaging with more coronary calcifications. So in this case, they have extensive plaque, so it makes it very difficult to see with EID, but reducing that beam hardening, we actually had 62% reduced radiation dose in the process of doing this exam compared to the EID study. So we're getting this excellent image quality. We're not compromising on the sensitivity, and we're also reducing the radiation dose. Here's some coronary and stent evaluations. It can clearly show stent lumen patency, and the effective dose on this particular case is 1.88 millisieverts. So very, very low dose, but still really ultra high resolution. But the exciting thing, I think, is not so much about the structures. I think it's very exciting to see this crisp, clear data. But this always-on spectral capabilities, utilizing those iodine maps for perfusion imaging, I think that this is really an exciting place to be in. So, you can clearly see, you can't miss the hypoperfused apex. But the other capabilities now, being able to suppress the calcium if you want in the coronaries, it's really just a matter of toggling on and off, because you already have the data. If you don't want to see it, good, turn it, it's really up to you as a clinician to be able to see and not see what you want to see. So this is another example, basically like a one-stop shop kind of study where it's a comprehensive cardiac evaluation with coronary stents and dense calcifications, again showing the myocardial iodine maps to show you the perfused area. So another example, comprehensive cardiac examination with coronary stents and dense calcifications. And then this is, again, like the one-stop cardiac application where we're actually, again, it just demonstrates that we have the universal full fidelity scan. It's on-demand reconstructions. You turn on and off the features that you want, and then you're able to continue. So I want to thank you for, sharing with you the exciting developments at GE Healthcare. Again, this is what our design goals are, to do all of these things, not just take care of one part, but really the whole entire wing-to-wing solutions of patients. And remember, and help you share that the reason, again, going back, the reason why we're doing this is for the patient and make the impact that really impacts patient care. So thank you very much for your time.
Okay, thank you, Deborah, for bringing us the newest technology from GE Healthcare. Now let's move on to our second speaker. Let's invite Rolf from Philips to give a talk on bringing AI technology and detector together to drive the advancement in the cardiac care. Let's welcome.
Thank you, Mr. Chairman. First of all, I'd like to thank the organization for the opportunity to present. And happy that you're still quite a large crowd here for what we as industry are providing to you. Well, I'm not a peer, I'm not a physician, I'm a radiographer by trade. Just a small anecdote, the first coronary CT in the Netherlands was performed in 1999. It happened to be that I was the radiographer, so already in the field of coronary CT for 27 years. Well, what I want to like to show you now is what are we doing? Well, bringing AI and the detector technology together to drive advancements in cardiac care. And the most important thing to remember, it's the patient outcome that counts, right? Conventional CT results often are inconclusive. And that will limit proper patient management. As you can see in the image on the top, it's the calcium blooming. It's one of the main reasons why patients are sent to the cath lab for these are false positives. Well, what can you do? What can you do, for example, with spectral CT, which we're already doing for 8 years, by using high monoenergetic images, and the image on the right lower panel, you can significantly reduce the blooming, and then you can see the apparent size of the calcium significantly shrunk, and this patient doesn't need to go to the cath, so you don't necessarily need photon counting or high spatial rest scanners for that. It's just when you use, in a smart fashion, spectral CT. Same like this, a patient with an occluded OM, and then is there a perfusion deficit in that territory? Challenging to catch. Well, experts might easily identify that, but junior residents might miss that, whilst if you start using spectral CT, low mono E in this case, on the right lower panel, you see a junior resident will be able to identify that with great confidence that there is a significant transmural perfusion deficit. So, what is the solution? I already told you, spectral is the solution. We already launched the ICON spectral CT, a 4 centimeter scanner, in 2016. A few years later, we came with spectral CT 7500, which was an 8 centimeter detector. And now, at RSNA 2025, we were very proud to launch the Verida, our latest and greatest spectral CT scanner. It's still an 8 centimeter detector, but it has a lot of novelties to it. Verida, what I want you to remember, it's smart, it's simple, it's spectral. Nothing more, nothing less. Smart, simple, spectral. So if we go through that, why is it smart? Well, it's smart because we've introduced a lot of AI tools in that system. So we all know, or you might know, that the heart of the spectral CT from Philips is our dual layer detector. Again, it's there since 2014, 2015. It's a dual layer technology which really provides 100% of the time, every patient is a spectral scan. You get conventional, you get spectral maps. There is no change in workflow, no change in scan protocols, no negative penalties to your acquisition protocol. So this is what you would always like to have. So the dual layer technology is the heart. So that's, of course, also there on our Verida scanner. But what did we do? Well, we also added an AI mechanism. So the detector, the dual layer detector, it's combined with AI-driven imaging chain, which allows for up to 80% radiation dose reduction, and we will significantly improve the contrast to the images. It's smart because it's also, the AI is also introduced in the reconstructor. And now we have high quality spectral imaging at speed for everyday use. So when you want to do 100 patients a day or 150 a day, what they see here in Hong Kong or mainland China, this is the volume that you're looking at. The reconstruction time was 110% faster, up to 145 images per second. A complete chest, abdomen, pelvis recon in 30 seconds. This is conventional, plus all the spectral maps that one can envision. And as you can see on the panel on the right, we see a patient with PEs, and then we can see it on the iodine map, or we can see it in a Z-effective fusion map. It also comes with a reconstruction technique, we call that spectral precise image. So it's an AI recon. And I showed here two images. The image on the left is what our current users are using, is IDOS. It's a hybrid iterative reconstruction. The image on the right is our novel AI reconstruction. I dropped an ROI to show you the standard deviation in noise. And you can see on the iDose in red, it's 25. If we copy-paste that ROI in left atrium and again extract the standard deviation in noise, it's 11. It's almost 3 times lower. Well, you can do the calculation in your ChatGPT and you will see that this will enable a significant and allow for a significant dose reduction. But there is more smart to it. You know, 8 centimeters, so we can't cover the heart in 1 beat, no. But we can do it in 2. But yeah, in 2, you always end up with these step artifacts, right? And you always end up with a broken vessel. And that's what many people do not like. Although from a diagnostic perspective, it doesn't have significant impact. But people just don't like it. Okay, we took that serious and now we've introduced Precise Z. So on the left hand, this is the initial reconstruction. Sometimes we see these stair steps. Some people are very dissatisfied with those. Well, no worry. Now the default reconstruction on your scanner is the image to the right. So no more broken vessels in 2 shots. So FFRCT is not an issue. We don't have broken vessels anymore. It's still smart. Why is it smart? Well, you see here, this patient has a higher heart rate. And then on our scanner, the temporal resolution might not always be successful. We don't have 66 like Siemens dual source. No, we have 135. And that sometimes results in residual coronary motion, especially in the mid-RCA territory. And then you end up with a non-diagnostic segment. And then the patient needs to come back or you need to go to the cath lab. Well, no more, because we have Precise Cardiac. What is Precise Cardiac doing? Precise Cardiac is an AI tool that helps to salvage that segment. And from a non-diagnostic blurred vessel, we change that into a highly diagnostic, motion-free segment. Nice publication from University of Utrecht telling us that the technology has excellent performance. And this is a patient with a 139 beats per minute. I put the ECG graph there at reference. We don't like to scan those patients. We all know the lower the heart rate, the better. Every vendor should say that, and you as users should know that. The lower the heart rate, the better. But sometimes patients cannot tolerate beta blocker. Sometimes in China, there is no time for beta blockers. If you need to do 50 cardiacs a day, you have to do something else. So you need to be smart. So we have Precise Cardiac in this one, and look at this heart rate, 139, exquisite image quality, combination of Precise Cardiac and our AI reconstruction Precise Image. Smart recovered, it's simple, and you know that. It's just scan the patient, reconstruct conventional, and in addition, you get spectral images for free. The radiographer doesn't need to be trained. It's scanning as usual. And the best thing is that the radiologist, you or the cardiologist, the cardiac imagers, they don't want to go to a separate workstation. That takes time. We need to think about a desired workflow. You can access spectral data at your fingertips on the PACS. There's a beautiful integration called Spectral Magic Glass on PACS. So you don't have to go. You don't have to leave your beloved PACS. You can easily push one button, within 3 seconds, this window pops up on your main PACS monitor, and you can access the data in low mono E and, or in iodine, and drop an ROI and calculate your iodine milligram per milliliter. So that is what is desired workflow, right? It doesn't impact the radiologist. It doesn't add significant amount of time. So smart, we covered. Simple, we covered. Now spectral. So let's have a look. And in cardiac, I told you the challenges, right? The challenges are high density calcium, blooming. We have issues with the stents. Can we see inside the stents? Non-calcified plaque detection, especially plaque composition, one of the most hot topics there is today in the research domain. That's all challenging, right? And then do not forget, when you read coronaries, you also need to look at the myocardium. Not only coronaries, also myocardium. So let's go through a couple of examples before I close. This is a patient with a stent, shown by our friends from Siemens, from GE. You see these. And that's where photon counting excels. Of course, spatial res, 20, 30, 40 line pairs. Wow, that's impressive. And I do like those, don't get me wrong. I'm not bashing spatial resolution here. But This is just scanned with the conventional line pairs, what we have today. I think this is already exquisite image quality on the panel on the left. And we see there in the mid of the stent, there is something dark there, right? Is that a metal artifact, a little bit blooming, a little bit motion, whatever? I'm not so sure. Well, what's the solution? Now, you might say spatial, but in Philips we say spectral. Because with spectral, I can easily change that map from conventional on the left to an iodine or water in the center image. Look at that. If I go to iodine or water, we get significant reduction of the stent structure, bloom. And now I can easily identify with great confidence there is significant in-stent racemose. On a conventional, I lose my non-calcified lesion because of the partial voluming of the high-density stent. So with this image, I can get the same diagnosis as on a photon counting scanner. Do you want to see stent structure? No. You want to see what's happening inside the stent, right? That's what spectral will bring to you. Plaque assessment. Non-calcified plaque, we know that. Hounsfield-based plaque characterization is inherently inaccurate due to significant overlap in Hounsfield units. Fat and fibrotic show significant overlap in Hounsfield, already published many, many times. And it's also highly depending on the iodine content in a vessel. So you can't use Hounsfield units. You can improve by spatial res, but still you're using Hounsfield units. So what's the solution? Spectral. Look at this. This is a mixed plaque, right? Calcified plaque and non-calcified. And now it's all about, is there a high-risk plaque feature, like a fatty deposit? There are two ROIs in that lesion, right? And they share on the left panel and the right panel, they share the Hounsfield units. They are similar. So I don't know, is this fat or is it fibrotic? I just don't know. What's the solution? Spectral. Because when we plot those ROIs and we ask for the attenuation curve, which is kind of the spectral signature of a tissue, you see that the magenta is going down when we go to 40 kef. Fat is the only tissue in the body which shows a decrease in CT number when you go to low mono E. Fibrotic tissue doesn't change that much. So you see with this graph, I am now super confident that there is a high-risk plaque feature. This part of the plaque shows a significant amount of fat. And that's how you do it. You just apply spectral. This patient had a tandem lesion in LAD, right? Significant, so probably a perfusion deficit at rest. And you can see that, we don't use it for quantification, but look at your LV myocardium, right? There is a little bit transparent there, so there's probably something going on. First pass perfusion deficit. Well, if you look at the left upper, which is conventional, is there a first pass perfusion deficit? It's the territory, but I don't know. Is the papillary muscle involved? Look at the left lower. A junior resident will identify that the entire papillary muscle is involved in the perfusion. Look at my iodine maps, which I can quantify. That's the solution, what you need to start using. This patient had some chest pain already 20 hours. The patient was late to the game, came to the ED. Pretty decent image quality, right? We see non-calcified plaques in RCA. Calcified plaques in Prox LAD, but look at the OM on the left lower. There is a total occlusion, right? Okay, first pass perfusion deficit? I don't know. If you go to low mono E, that's first pass perfusion deficit, you see there is in the OM significant transmural. Okay, what is next? You're going to do a late iodine enhancement scan. So you're going to wait 7 minutes. And then you get this. This is amazing. Look at the quality, 40 kef, delayed iodine enhancement. And you see, you can now differentiate between the salvable tissue, the penumbra, and the core infarct, MVO. That's what spectral will bring to you. So there is significant value within cardiac CT. And now people see the value of spectral. So now, this is from Japan. People are starting using it in typical MR indications. Amyloid, sarcoid, this patient had hypertrophic cardiomyopathy. First of all, look at the image quality. This is spectral precise image. This is the AI reconstruction. Exquisite image quality, if I may say. State of art. And then you can look at the myocardium. You do a late iodine enhancement scan, and we see the scar. MR territory, but I only say when there is a contraindication to MR, either the waiting list is too long or the patient has claustrophobia or incompatible devices, you don't have to despair. You can easily use spectral CT to get this to this level of diagnosis. And this is the best case. This is my last case. The one-stop shop. Spectral CT, it's a desire which everybody had for 20 years in cardiac. The one-stop shop. This patient had chest pain. Came to the ED. There was slightly elevated troponin, but the coronaries were normal. So what do you think? Your differential? Well, Minoca, well, myocarditis? Yeah, probably myocarditis. Let's go to MR. But the patient has claustrophobia. Patient cannot go into the MR. What do? Despair? No. You wait 7 minutes. And then you get your late iodine enhancement. Look at the left lower, 40 GeV. You won't see better images than this. This is state-of-art spectral CT. And then we get spotty subendocardial late iodine enhancement. You can see it in iodine. And when you have iodine information, quantification of iodine, at 7 minutes, I can give you extracellular volume. Extracellular volume with CT? It takes 30 seconds. And then you are able to extract and quantify the extracellular volume of this patient. Multiple studies now show that there is an excellent correlation between ECV MR versus ECV spectral CT. So this is a really, really cool scenario. This is the one-stop shop. Now, this was my last slide. I show you, I promise you, if you want to see more, please visit us on the booth. We have multiple examples to show. And otherwise, tomorrow at 1:30, we have a lunch symposium hosted by Professor Damiano Coduso from Rome, La Sapienza in Italy. Thank you very much.
Okay, thank you, Rolf, for the nice introduction. Here now we have the Q&A session. If you have any questions, please step up to the stage. There's a microphone and raise your question. So I think we still have several minutes for Q&A. I have a question for both of the speakers. As you both nicely shows the motion correction algorithms either by the from the GED snapshot freezing, or also from Philips, the precise cardiac. So what is your comment of those motion correction algorithms compared to the physically improved temporal resolution, for example, by the employment of a dual source system? So with the help of those motion correction algorithms, how much higher the heart rate can a patient be allowed to be scanned for successful coronary imaging?
You go first. Ladies first.
For GE's perspective, I don't have the actual quantification of how high we can go. I know just from experience and from what we were able to do, we routinely see over 100 beats a minute. I mean, it's just we see it. Is it optimal? No, but the temporal resolution applying the motion correction even to high rates are achievable. So how high, I can't quantify that, but routinely it really takes care of the motion correction, and it's quite impressive.
Okay. Rolf?
Well, in Philips, and I'm doing cardiac for 26 years, and I know in the guidelines SCCT is the recommendation of beta blocker is there. It's in the guidelines, so you should, even on photon counting with 66 milliseconds, you get the best image quality. And that's what you need in stents or whatever at lowest heart rates. So I always say, beta blocker, please use it. But of course, there are patients who do not tolerate beta blocker. There are patients, countries like China, where because of the pressure, the workload, you cannot give. So does it change precise cardiac? Does it have an impact? Yes. First of all, the threshold for our step and shoot, right? The axial prospective scanning. We have a threshold. We usually use 65 for coronary CT step and shoot. And now with precise cardiac, our users tell, well, we now dare to do a step and shoot, which is at a low dose, of course. We can now increase that threshold up to 80. In helical scans, it also works. So again, we all have these cases where in a patient with 140, I showed one, where we have exquisite image quality and precise cardiac works really well. But not always. And if everybody's honest, you would say, yeah, sometimes it's there and sometimes it isn't there. So temporal resolution without tools like MCR, 66 milliseconds, yeah, that's great. But again, no guarantee either at 66, right? There was an exhibit out there showing that even on a dual source, when you give beta blocker, you have to give beta blocker, you get the best image quality. So there is no secret there.
Okay, final question. Because both of the vendors shows very nice images of the myocardium of the plaque, especially with the help of those novel techniques, either by the photo counting from GE, the Photonova, or by the dual detector CT from Philips. But in case of that, there is an explosion, data explosion that our radiologists or cardiologists acquire now with so much information. The efficient way to analyze is very crucial for the either the image analysis or the to improve workflow. So from your vendor side, how could you help us to read, to interpret it, so much information that acquired either now or in the future by the those novel technologies?
Well, I'll go first now for this one. Well, I kind of alluded that already to it, right? Smart, simple, and spectral. Simple, it has to be simple, it has to be easy, otherwise the radiologist will never adopt. Right? You have novel technologies, we see that with photon counting, we see it with spectral. Novel technologies, they need to get adopted. And that is highly linked to how do you bring these additional images in a tangible fashion to the cardiac imager. And in Philips, we have this beautiful solution. Our friends and enemies say, oh, wow, this is what I need. It's a seamless integration with PACS vendors. Vendor neutral. It doesn't have to be Philips PACS. It can be GE PACS, Siemens PACS, whatever. It's just one push of the button, and you can change your conventional in 1 second to low mono E. Or if you think I'm looking at a stent, I'm going to use iodine or water. Or if you're looking at a plug, I'm going to use Z effector, for example. It's just this integration on the PACS that makes it, that's for the cardiac imager, it's not needed to go to an advanced workstation. So that is smart, and that's how we do it, and that's how our users really like it.
Okay, thank you.
I can add from GE Healthcare, I've already alluded to the software called CardIQ Suite, and what we're doing today is a guided workflow. So, in the technologist area, when we're doing effortless workflow, we're allowing the software to apply AI automation to basically automate what can be automated, right? We don't want to take away the expertise of the clinician, but there's things that can be automated, and that's what we allow AI to do and send directly to the PACS. But the guided workflow takes what you have as your reading protocols, guides you through there, guides you through the steps so that you can get to the final conclusion. Is it perfect today? No, I don't think so. I'm in product development, so I'll never think that anything is perfect because I want a job, so we want to perfect things. But I see a day where we're actually augmenting, and this is a visionary statement, but I see a day when we're actually wanting to augment and having workflows where we're using AI using large language models to basically help not only guide you through the interpretation, but also let's build that report for you. Let's help you get to those answers, predictive algorithms. That's a vision that I see in the future that's very probable, and that's what we want to work towards. There's no reason why we want you to do these administrative functions. We want to help you get to the conclusions and then be able to let you be the clinicians and be the people that can actually help the patients do what you do best.
Okay, thank you very much. Here is a question.
Excuse me, can I ask a question? To GE, thank you for a very, very comprehensive discussion. 2 questions. Number one, for people who are claustrophobic, is your new photon counting equipment, is it big enough for big people?
Yes, it's, if you look at it, just by looking at the scanner, it almost looks like your Revolution Apex scanner. So the actual size of the gantry and things like this is very similar to the actual like Revolution Apex scanner. So for claustrophobic patients, I don't think that there's really a problem with that. And then also with our usability designs, we work actually with patients and then do some of the testing as well, just to make sure that we can also enhance with colors, with things like this to help their patients with claustrophobia get through the experience. But we're talking about 2 heart rates. It's not like an MRI scan, right? So the amount of time that they're actually in the scanner and doing these things is really minimal. So, but thank you for the question. I think it's really important to have the patient's perspective. So thank you very much.
Yeah. The second question is, as you're so innovative, I was wondering, with scanners, we're always wondering where patients who are iodine sensitive. Do you have any ideas as to whether in the future we can use another contrast agent, which is not iodine-based?
This I don't have the answer to, but I think the exciting thing about using photon counting, using these new energy detections, I talked a little about the digital fingerprint. I think that there's so many technologies of being able to do this. I'm just kind of wondering if the day of non-contrast is, it's in our future, right? But I'm wondering if we can get to the point of being able to utilize our energies and maybe not have to use contrast, or maybe, virtually pretend you're gadolinium or things like this. So I don't know. I don't know what that future is. I'm hoping that researchers here in this room will help us discover that. But I think the future is wide open for that possibility.
Thank you.
Thank you.
Okay, if without any further question, we are coming toward the end of this session, and thank you for the excellent lectures.